Good evening, all my dear students. We've had some nice basic principles of surgery discussions so far. Today, let's move one step ahead and start with core general surgery. Easy but interesting questions lined up, not so difficult for general surgeons, which I hope to finish discussing today. Whatever get left, if any, we will carry forward in the next session. That's next Wednesday. The plan for the month is going to be general surgery in terms of core principles, followed by head and neck and thyroid. That is the plan for the next few weeks. Hope to see you guys engaging as you have been over the last few weeks. All right, so let us begin. I am Dr. Amrit Nasta. I am a bariatric surgeon from Mumbai, and today we will be doing the general surgery module from the Conceptual Surgery book. Please be interactive like you have been over the last few classes, and the faster you respond, the more questions we will be able to cover and the more we will be able to discuss. Okay, let's start with something. Many of us may have faced it in our operative patients or may not even have realized it. We know there are different types of shock, but what does neurogenic shock typically show? What are the unique features of neurogenic shock? Hypertension and tachycardia, hypertension and bradycardia, hypotension and tachycardia, hypo and brady. Let me see if anybody can figure it out. Yes, Dr. Behera is saying hypertension and bradycardia. Let's keep it simple. When we get these kind of questions, let's not rack our brains too much and make a mess of it. When you see the word shock, okay, simple principle. When you see the word shock in one word is always going to be hypotension. Okay, and then you know there are various types of shocks. But when I say shock, there has to be hypotension. That's when I call it shock. So A and B are gone. Now, conventionally, shock is associated with tachycardia, like hypovolemic shock, hemorrhagic shock, septic shock that we see in our patients. They typically have tachycardia, which is a body's reaction to volume loss. In neurogenic shock, you get bradycardia. Anybody can give me any example? Why would someone get neurogenic shock? Why do you get neurogenic shock? Like we know, we always see septic shock in surgical patients, leak, wound infections, you get sepsis, abscesses, or you get hemorrhage and hypovolemia. We don't really see neurogenic. Any scenario where you face neurogenic shock? Rare scenario. It is typically seen in spinal cord injuries. Yeah, excellent. It is seen in spinal cord injuries. It can be sometimes an effect of spinal anesthesia. Okay, it can be seen as a side effect or rather an adverse event after spinal anesthesia. That is neurogenic shock. In what category of shock does neurogenic shock come? Like if I ask you what are the different types of shock, there are two main groups. One is where there is decreased flow or decreased perfusion because of maybe volume loss, where you have hypovolemic shock or hemorrhagic shock, or you will have cardiogenic shock where the heart is not pumping enough blood, or you will have obstructive shock, which is seen in patients with cardiac tamponade. What type of shock is neurogenic shock, where you also get septic shock? They come in the same category. It's a very important category. It is called distributive shock. There is no volume loss in distributive shock. So distributive shock is sepsis or septicemia or septic shock, anaphylaxis, and neurogenic shock. Neurogenic simply means, if I ask you in one word, there will be loss of sympathetic activity or loss of sympathetic outflow. Okay, blood will get pooled in the periphery, kind of like septic shock. That's why it is distributive. That's why bradycardia. It's because the sympathetic activity is gone. All right. So that was question number one. Let's move on to this. This is a VVIMP question. It is asked in many entrances across the years. NEET, PG, super specialty. You go there, they will ask you this. Which of these is the most reliable method for monitoring fluid resuscitation? So you have an idea of the kind of questions we are discussing. Fluids, electrolytes, nutrition. Those are the core general surgery topics that we are discussing, which conventionally we don't pay any importance to. We are focused so much on GI surgery, uro, trauma, that we don't focus on these topics. And that's where we lose our ranks. That's where we perform poorly even in our MS and DNB exams, let alone clinical practice. Most reliable method for monitoring fluid resuscitation. So if someone is hypovolemic, how do you know when to stop? Where you are giving him enough fluids is always going to be urine output. What is the target urine output? When do you say he is having adequate urine output? And that should imply, yes, adequate resuscitation. What is the target urine output? In someone undergoing resuscitation, means lot of fluid loss, maybe after surgery and bleeding, or maybe after gastroenteritis. When do you say his urine output is adequate? CVP, the problem is if someone has cardiogenic shock, his CVP may be high. Pulse rate takes a long time to get corrected. Pulse rate is lost the earliest. It is one of the first signs of shock. So is blood pressure, not very reliable. The target urine output should be 0.5 ml per kg per hour. Okay, 0.5 ml per kg per hour. That is your target. Which means if the patient is say 50 kilos, he should pour at least 25 ml of urine per hour. Alright, and so on and so forth. Parenteral nutrition is not preferred in. The question is not preferred, or where do you avoid giving parenteral nutrition? Parenteral nutrition is what we call TPN. Where is it not preferred? Intracutaneous fistula, burns, Crohn's, pancreatitis. It's a little ambiguous. So I will tell you what is the best answer and why did I reach to that answer. Where will I not prefer TPN? Because conventionally, the feeding of choice is always going to be enteral. Whatever is the scenario, wherever you can use the intestines, you should go for enteral nutrition. Please see the modules, please see the videos in the CS app on nutrition or surgical nutrition. They are the core tenets of general surgery, which you can't be away from. So parenteral nutrition is not preferred in. Yeah, let's see. Some people have answered burns. Okay. In intracutaneous fistula, of course, you would avoid using the intestines because it's an intestinal disease. So avoid intestines or avoid enteral. So you will prefer parenteral. Same holds good even for Crohn's disease where there is a lot of hypoabsorption if the disease is flared up too much. If you want to give some rest to the intestine, you would avoid enteral. Now the problem comes between burns and pancreatitis. The problem with burns is many times in burns you get paralytic ileus. So the best answer here would be pancreatitis. If they ask you what is the preferred feeding modality, if the person is not taking orally, what is your answer? Preferred feeding modality if patient is not taking by mouth. If he is not taking by mouth, what is your answer? What feed will you give him? And I will tell you what Bailey says. Yeah, excellent. That's an excellent answer. You know, as a resident, our answer or our choice was nasojejunal, but Bailey says no, go for nasogastric feeds. Because what Bailey says is use the stomach. There is no need to rest the pancreas. This is given in Bailey. There is a new edition of Bailey which has come up a few days back. Please purchase it. It will be like a mountain of MCQs coming from there. 20th edition. It has come in 2 volumes. So there is no need of giving rest to pancreas in acute pancreatitis. This is what Bailey ka 2018 edition said. Let's see what 2022, which came few days back, says. Interesting times. True about TPN. So many of you would have used TPN in your surgical patients. Which of these is true? Carbohydrate forms 40% of energy source. In abdominal injury, early parenteral nutrition should be started, not stated, started. Proteins from 60%, lipids from 20%. A little tricky question. A few words here and there have been changed. But they will test your funda like this. I will keep saying this in every class. Now that you have only one entrance, means 150 questions, and not specialty specific, they will ask you a lot of general surgery. Because they know this is where students will fall. And that's how they will differentiate you from normal students. True about TPN. Carbohydrates form 40% of energy source. No, they form about 60 to 70%. TPN tries to mimic, I'll give you how to remember, tries to mimic normal diet or normal nutrition. That's why it is called total parenteral. It's not called parenteral. It is called total parenteral. Total means it should be as close to normal as possible. In our normal diet, carbs are 60%, proteins are 20%, and fats are 20%. That's how we normally eat. The answer here becomes lipids form 20%. Proteins would also be about 15 to 20%. So this question, early nutrition should be started. If I ask you, what is the main time indication to start TPN? Like patient should, if I anticipate that patient will not be taking orally for how many days, then I should say, oh yes, let's start him on early TPN. Because many times we have a tendency, he has paralytic ileus, post-op, he won't take orally for maybe 1 or 2 days, then you can start him. So no need for TPN. So what is that time frame? If I know he is not going to take orally for so many days, start him on TPN. That's what I'm trying to ask you. Clinically relevant. Because we can anticipate, like if he has a fecal fistula, intracutaneous fistula, I know he's not going to take orally till the fistula heals, which can be weeks to months. So start him on TPN. What is that anticipatory timeline? 1 week. So what Bailey says is 5 days. Okay, 5 days. If I know for 5 days he's not going to take orally, better to start him on TPN. Alright, let's move on. You would have seen this TPN bag. What are the components of TPN? What all does the bag give you?